Greetings. Let us talk about how do you classify ascites. I want to thank many who support this program, and please take a minute to review this notice. And here is a gentleman who has ascites, and you could actually see that he has ascites when you stand at the foot end of the bed. Uh, the abdomen is grossly distended and bulging. And you can also see an umbilical hernia through the uh, covers. So this is a grade 3 ascites. And how about grade 2 and grade 1? Grade 1 is something you will not be able to detect clinically. You need an ultrasound for detection. Ultrasound to detect free fluid in the abdomen. Grade 2 is ascites that can be detected clinically. Patient will have distension of the abdomen, bulging flanks, but not as marked as you see in this picture. They'll have uh, dullness to percussion in the loins, shifting dullness, and they may have a little bit of fluid thrill. On the other hand, grade 3 is marked distension of the abdomen. So when you see a patient in the clinic, you have to classify ascites into one of three groups because this is important in terms of the management. Grade 1 probably doesn't require treatment. Grade 2 needs therapy, uh, and the therapy is usually a combination of salt restriction, sodium restriction to less than 2 grams per day, and a combination of aldosterone antagonist and loop diuretic, spironolactone and furosemide. And with that, if the patient loses weight and ascites resolves and clinically not detected, you call that ascites as something that has responded to your medical management, otherwise known as responsive ascites, responsive to therapy. So, on the other hand, if you have a patient uh, who has responded to therapy, and you look into the history, and he has done well without any recurrence. That's great. On the other hand, if the patient coming back with the reaccumulation of ascites multiple times in a year, at least 3 times in a year, you call that as recurrent ascites. So we talked about responsive but recurrent ascites. So as the liver disease gets worse, in the initial stages, the ascites is quite responsive to therapy. And as the disease gets worse or the patient is not compliant, the patient will develop recurrent ascites. And in later stages, you may get into trouble managing the ascites. And in that case, before you label that patient as having refractory ascites, you need to look at three important principles in the management of ascites. Is the patient on a salt-restricted diet, less than 2 grams of sodium? And if that's the case, you know that the patient is compliant with sodium restriction. So that's one thing you need to establish. Next one is the patient on diuretics, a combination of aldosterone antagonist, spironolactone, and a loop diuretic, furosemide? Did you maximize the dose to 400 milligrams of spironolactone and 160 milligrams of furosemide? And even with the maximum dose, if the patient still is not mobilizing the ascites, then again is a problem. Sometimes as you try to escalate the dose, you start with 100 of spironolactone and 40 of furosemide, and the patient doesn't respond. You increase from 200 to 80, and then 300 to 120 milligrams of furosemide, and 400 milligrams of spironolactone, and 160 milligrams of furosemide. And as you're trying to do that, if the patient develops side effects to diuretics, then you have a problem in getting rid of the ascites. So you talk about salt restriction and diuretics. Talk about those two things. And then finally, if the patient is on a salt restricted diet and a maximum dose of diuretics, you see whether the kidney is able to excrete the sodium. And you can check that by using 24-hour urine collection for sodium. And despite salt restriction and maximum doses of diuretics, if the sodium in 24 hours, sodium excretion in 24 hours is less than 90 milliequivalents, or if you don't have ability to collect 24 urine and you want to go with a spot urine sodium slash potassium ratio, and that is less than 1, you know that the patient is not able to get rid of the sodium. And uh, in, in this condition, you consider the diagnosis of refractory to ascites. In other words, refractory ascites is patient is sticking to the diet. You are happy with the maximum dose of titrating the dose to the maximum combination of spironolactone, 400 milligrams and 160 milligrams of furosemide. And despite these two, the kidney is not able to excrete sodium or expel the sodium. Then you consider the patient has refractory ascites. So in this situation, you have limited options. How do you manage the patient's ascites? And that's when the question of large volume parasitosis comes into the management of patients with cirrhosis. I want to thank authors of this guideline. I've learned a lot, and I encourage you to read this guideline. And thank you for your time.